Good evening and welcome to blackdoctor.org. I'm your host tonight, Shamika Rhymes. Let us know where you're watching from in the chat. I know we're all a little bit on edge tonight as we're waiting for election results, but let me know where you're watching from. In honor of National Diabetes Month, this month, November, we're kicking off part one of our special diabetes series. Now, throughout this series, we'll be exploring what diabetes is, how it affects the body, and most importantly, what you can do to prevent it and manage it effectively. So make sure you stick around, share this with your network, your family, your mom and them, everybody. So, because there's some valuable expert advice that will be given tonight, and you don't want to miss out on that. And also remember to put any of your questions, comments in the chat, and we'll try to get to those as we go along. So let me introduce you to our panelists because we have a great group of people joining us tonight. So first up is Dr. Dominique Woods. She is the president and CEO of Limitless Impact Foundation. Hi, Dr. Woods. How are you?
Hi, good afternoon and evening, everyone. Pleasure
I feel
to be
like
here.
I'm at Showtime at the Apollo as I'm welcoming everybody. Show your love. Next up, we have Carolina Castillo. She is a registered dietitian at Cedars-Sinai Medical Center. Hi, how
Hi,
are you?
everyone. Good, I'm good. Thank you for having me.
And then we've got Gregory LaFortune. He is a registered dietitian. He is also joining us tonight.
Good evening, everyone. Happy to be here.
Welcome, welcome. So tonight, as I said, we're kicking off National Diabetes Awareness Month. And so let's start with Dr. Woods. Can you explain what is diabetes? Because I think there's sometimes some confusion, especially when you throw pre-diabetes in the mix. So can you kind of give us an overview of what is diabetes?
Sure. So when we talk about diabetes, we are referring to diabetes mellitus, which is the common type we all know, but there is another kind that we won't get into, but the more commonly referred to one is one that affects your blood sugar levels. So everyone knows somebody who's affected by diabetes, and we can break those into two types. Right. So we have type 1, which we associate with autoimmune dysfunction, usually found in kids, juveniles. There's type 1.5, which we won't go into, but that's more of a later onset. And then there's type 2 that we're more familiar with, which has to do with the metabolic changes that happen when we reduce our insulin production in the pancreas. So as you know, when the body is responding to a high sugar load, the pancreas produces insulin to bring that glucose into the cell. So diabetes, as we know it, is a disorder in either the production of insulin or the sensitivity of insulin. So the body's, the cell receptor's ability to respond to insulin to bring sugar into the cell. And so that results in elevated levels of blood sugar or blood glucose, or some of us should say our sugar, which can do damage to our organs. So our end organs are those organs that have small blood vessels. So from top to bottom, we have our eyes can be affected. So we know people can go blind from diabetes. We have our kidneys, the small blood vessels. So sometimes people can have a transplant or kidney dysfunction because of diabetes. Also, we can have heart attack, right? That can be affected, as well as problems with your feet. So neuropathy or nerve damage to your feet from diabetes, as well as amputation, which I'll be speaking about later.
Okay, thank you. And I guess this question is actually for all of you. So we'll kind of there will be moments where we'll just kind of have a conversation, just jump in wherever. And there's some where I'll kind of be like a teacher and call on you. But for this question, how does type 2 diabetes particularly impact the Black community compared to other communities? Like, what have you seen, even as dietitians? What have you seen? And Dr. Woods, let's just start with you, and then we'll just go around the room.
Sure. So unfortunately, the groups that are most impacted by diabetes are Black and Brown populations. So those people who are historically marginalized or racialized. So there are various reasons why that happens, but really it's due to access to care, health literacy, our diet, our cultural values, but really it's education and awareness. So those groups that are impacted, unfortunately, don't know the risks of developing diabetes and then also don't have the resources to be able to treat diabetes effectively. So when we're talking about amputation, for example, unfortunately, the data bear out that Black Americans are 3 times more likely to undergo an amputation due to diabetes as compared to their white counterparts. So it's definitely something that hits our community harder than other communities.
Thank you. Gregory or Carolina, either one of you want to weigh in?
Yes, I mean, I also think going back to the, feeling marginalized, also not to bring the Latino community in, but since I'm also Latina, but I do, when I see patients, specifically, Black Americans or also the Latino, I think that there is because of this marginalization that has been happening for, a long time, I don't think there's, they don't ask a lot of questions. You kind of have to dig, from the provider perspective a lot and ask a lot of questions. And there's no, I think, it's lacking a little bit from their curiosity on what they can do or how can they get better. And I think it's coming from that. I don't know if they feel intimidated when they're with a doctor or a provider, and they just preferred not to ask instead of maybe asking a question that might sound not very smart or something. I think that also is one of the factors that doesn't help them.
Okay,
Yeah, I
thank you.
agree. And just tying in a lot of like trauma throughout the history of Black people here in the US definitely ties into rates of diabetes that I'm seeing, that I'm experiencing when I'm counseling people. And I work with a lot of men. So a lot of my work is with men, and that sense of I'm kind of like above healthcare, or maybe it's more tied to cultural factors and societal factors and et cetera. But like Black men, for example, are at an increased rate of developing diabetes. And also, to what I'm seeing too, is this whole notion that somebody goes get their A1C checked, which is a test that helps you determine your diabetes, or where you stand when it comes down to like how well your insulin is functioning in your body. They may get a diagnosis of pre-diabetes and think that they don't really need to do anything, right? You have a lot of doctors and healthcare providers telling people, whether white or Black, like oh, you're fine, like it's nothing to worry about, and then they literally do nothing, and then a year later they come back with heavily impaired blood sugar levels, and then now having to take some form of medication. So it's that awareness, it's detecting early, and it's also taking action early as well.
Yes, thank you for that. Which actually I wanted to ask Dr. Woods about, since Gregory mentioned this, about that A1C when you go to the doctor. And I know for myself, I've heard the whole pre-diabetes, and I've heard it for years, but then it's like, well, what do I do? And crickets. But I don't know that everybody understands exactly the whole A1C thing and what normal A1C looks like. Can you kind of talk us through what that looks like?
Absolutely. That's a really good question to bring up, because people don't know the risks when it comes to prediabetes. So let's back up and let's talk about how diabetes is diagnosed.
Okay.
So an interesting statistic that I think we should bear in mind is that by the time someone is told you have frank diabetes, they would have lost at least 50% of their pancreas's insulin production. So a lot of people don't know that diabetes is an insidious disease. It's a chronic disease where by the time you know something is happening, a lot of the damage has already been done. So that pre-diabetes factor is what's so important. So let's discuss how someone can detect that they have diabetes. So sometimes people have symptoms, sometimes they won't. So those symptoms can include fatigue, we call polyuria, so peeing a lot, urinating a lot, polydipsia, which is being thirsty, or they have polyphagia, which is being hungry all the time. And so we see in type 1 diabetics, they may lose a lot of weight, and that might be a signal what's going on. So it's important to know that not everybody has symptoms and not everybody is aware, because some of those symptoms might be non-specific, like fatigue, for example. So when you go to your doctor, they may do what's called a hemoglobin A1C. So what that is that's a measure of how much sugar is attached to the red blood cell. So we call that glycosylation of hemoglobin. So that's reported in a percentage. So what we're looking at is the percentage of red blood cells that have a sugar attached to them over time. So the red blood cell, the lifespan is about 3 months. And so that's why the hemoglobin A1C is typically checked in a range, an interval of about 2 to 3 months, right? So when we're looking at hemoglobin A1C, there's a value that we can associate with about the average level of someone's blood sugar. So a certain percentage of red blood cells that we seeing sugar all the time or at an elevated level, those red blood cells are likely to be glycosylated. So the normal value for the percentage of red blood cells that have this sugar attached to them stops at 5.5. So once we get into 5.6 and above, all the way to 6.5, now we're dealing with prediabetes. So what that's telling us is our average measure of blood glucose is elevated. And that typically corresponds to a fasting blood sugar that's above 100 to all the way to 125. So prediabetes should be our marker. Hey, something's not right. We're not processing our sugar appropriately. So that should be where folks like Gregory and Carolina get involved and say, what do we need to do to modify your diet? And so when someone has frank diabetes, that's when their fasting blood sugar is 126 or above. You can also diagnose diabetes with a hemoglobin A1C as well, where you don't need to be fasting. And that magic number is 6.6 and above. So there's another way to diagnose diabetes, which is you don't have to be fasting. And if your blood sugar is above 200, that's also another way. So there are 3 ways that you can do it. So looking at your fasting blood sugar, right, being 126 and above for diabetes, and then your hemoglobin A1C being 6.6 and above, and then a random glucose being 200 and above. So I'd like to turn it over to my counterparts to discuss why it's so important that people know that number and if they're pre-diabetic. And I have to say that I've been pre-diabetic. It happens to a lot of us, and I made some changes with my lifestyle and diet to get my hemoglobin A1C back to normal. And so I want to encourage folks with the information they're giving you that it can be done as long as you are following the advice of someone who can help you, like a dietitian. So I'll turn it over to you guys.
Yeah. Thank you. Thank you for the explanation. And I just wanted to co-sign real quick. I did the same, turned it around with a dietitian. So so Gregory, Carolina, please weigh in.
Yeah, I'd love to just kind of add on. So a lot of people also should understand that that hemoglobin A1C test is pretty important because, a lot of people say like, can I just prick my finger and check my blood sugar and know if I have diabetes? Well, your blood sugars are fluctuating naturally throughout the course of a day, right? 2 hours after you eat, your blood sugar is supposed to be a little bit higher than if you were fasted, right? So Dr. Woods went into that very well. Because that blood sugar that you take at that finger prick, this takes like a brief snapshot of your blood sugar at that moment that can be impacted by what you just ate, if you didn't eat, if you spent the whole day not eating and you just exercised, and etc. But that hemoglobin A1C test definitely tests for that past 2 to 3 months, as Dr. Woods said. So that's very important. So it's really important to know because, in my personal opinion, insulin is probably one of the most important hormones in the body because it really helps to metabolize carbohydrates. And there are carbohydrates in almost everyone's diet, unless you are an avid keto diet person, which I normally don't advise, but everyone to some degree eats carbohydrates in different amounts. And that insulin that your body produces is helping you to metabolize or to break down that carbohydrate and to put it into your muscles and to put it in different parts of your bodies for you to be active and healthy. Now, if your insulin levels are impaired, aka if your A1C is out of whack, that can really affect how your body is treating the breads, the pastas, the sweets, the fruit, the dairy, the starchy vegetables, and etc. that you are eating. And it's really important to know because you could possibly be worsening your blood sugar by continually eating some of these things. Not to say that you need to restrict or remove, but knowing that number just kind of gives you a good idea of how your body is handling those carbohydrates that you consume. Also to dietary fats too, but mainly carbohydrates.
Thank you.
Yes.
Carolina?
I mean, I agree with, they both explained it very, very well. And I think that it's a good, also to, once you kind of get that reading, whether it's, it's a pre-diabetic or a pre-diabetes diagnosis, I think it's really important for them to, for the patient to ask as many questions as you have. How did I get this? Why did I get this? How can I improve it? Because a lot of the times I think that sometimes the doctors don't have the time, and this is where the working with a dietitian, really helps. But kind of getting a little bit more information from the doctor as what they can do immediately, right? And then eventually if they're able to meet with a dietitian, that would be great. But once they have those numbers, to have the doctor kind of explain to them how the diabetes works. A lot of the times I tend to see that if the patient understands how the diabetes works, they're a bit more able to do it and kind of change and know the reason behind why they're doing the changes to their diet.
Okay. Thank you. This was a great explanation, because I think for one, I've never heard it explained as well as you guys just all explained it. But what would you say is the primary risk factors for diabetes, and how much is genetics? Like, if your parents or your grandparents had diabetes, does that mean that you are susceptible? So I can't even talk. That you could have diabetes at some point, or is it just really based on what you're eating, lifestyle, all those things? I'll start with you, Dr. Woods.
Sure. So when we were talking earlier about the different types of diabetes, most people know about type 1 versus type 2. And in the past, we associated type 1 with juvenile onset diabetes. Like, oh, that's the genetic one. And then type 2 is, oh, you just don't take care of yourself. You don't eat right, etc. But what we now know is that type 2 actually is more genetically involved than we thought. And so we know that because we found out that there are more genes that are associated with someone developing type 2 diabetes. So we call that polygenicity, or basically saying more than one gene. So I want to draw to people an example. Think of someone that you know, and you might say, okay, this person, I know they don't exercise. I know they're not taking care of themselves, their diet, they may be obese, but they haven't developed diabetes, right? And that's because they probably don't have the genetic predisposition for developing diabetes. So we have to rethink the way that we're thinking about diabetes and take away that stigma and realize that a lot of this is determined by our genetics. And so we call it the 2-hit theory, which is somebody has their genetic predisposition, and then because of lifestyle factors, the environment, right, the nature versus nurture, the nurtured part is related to our activity levels, physical activity, and as well as our diet and how we are controlling our blood sugar throughout the day. So I really want to encourage people to understand that it's really a new day that we're talking about diabetes. Like, we have these big blockbuster drugs like Ozempic, Wegovy, Mounjaro, and that's really to take away that stigma that sometimes you're doing all the right things and you just have the genes for it. And we need to take that stigma out. And definitely we'll be talking more about that in the series as well, that really diabetes is one of the oldest diseases known to man, and we still don't understand a lot about it, but there are things that we can do to empower people where they don't have to feel like they're a victim to the disease, and also the stigma and the complications that are attached to it that can cause them to lose their life and their limbs. So it's important we talk about this.
Thank you. Gregory, I want to start with you with this question. What are some preventative steps that people can take to reduce their risk of, is there some kind of diet that they can start on so that they don't develop type 2 diabetes, or if they just can stay in that pre-diabetic range? I know we want to get out of the pre-diabetic range, but is there something they can start with now before it develops into full-blown diabetes?
Yeah, and before I talk about diet, I mean, some really the unsung heroes of diabetes prevention from a lifestyle perspective is getting adequate sleep, right? If we can really focus on getting sleep, because studies have shown that who do not get enough sleep are at risk of increased blood sugars, um, more what we call insulin insensitivity, in which Dr. Woods explained that the cells are not uptaking that insulin and moving that blood sugar into your cells, and it's staying inside the blood stream. So getting adequate sleep is a really great place to start. Also, too, factors like stress. I know stress can't always be controlled, but really managing stress and finding mindful ways to manage stress, partaking in hobbies that you love, spending time around people that you love, doing things that you love, reading, listening to music, meditation, for some people praying, all these stress management factors can really help. From a diet perspective, there's a lot of things we can talk about. It's not always about changing your diet per se, but oftentimes it's really just adjusting the portions of what you are consuming. My parents are from Haiti. My folks are from the Caribbean, and a staple of ours is going to be rice, some kind of starch. And a lot of them are here in the States, and I'm providing education. And, back in Haiti, they were walking all the time and they had the energy, they were always in some form of like energy burning mode because they're walking, they're doing some kind of activity. Now they're here in the States, a little bit more sedentary, eating the same exact way, and end up developing diabetes. And I'm just going into like, hey, what can we do? Oftentimes it's just adjusting the portions and saying, hey, instead of like this being your entire plate, let's focus on like maybe if that starch, aka the rice, the bread, the pasta, etc., can be 1/4 of your plate. The 1/2 of your plate can be the vegetables, the non-starchy vegetables, and then that other 1/4 is your protein. If we can get closer to this is one thing from a nutrition sense, or from a nutrition space, that we can really do to help limit our risk, and also to help decrease our A1C if we already have diabetes.
Okay, thank you. Do you have anything to add to that, Carolina?
Yes. So I
I tried
agree
to
with
leave some for you, Carolina.
I'm sorry.
I said I tried to leave some content for you.
Thank you so much. Yeah, I was, hoping, don't say the ones that I have. So I agree with everything that Gregory says, by all means. Yes, those are all true. But two of the things, that I like to tell my patients is, number one, it also matters how you eat and how you create your meal. So I always tell patients, whenever you're going to eat something, regardless if it's a meal, a snack, something extra that you wanted, ideally have your protein first and then go for that starch or carbohydrate, as Gregory mentioned, the rice, the pasta, the ice cream, right? And it's not about either I can have all the ice cream that I want, or I have to completely avoid it, right? It's again kind of, like Gregory, specified, is about portion size. But one of the things that I usually tell a lot of my patients is ideally eat your protein first, because the protein then helps ideally to slow down the digestion and the absorption of those carbohydrates that you're going to have. So that's one of the other things that I also tell patients. And then the other one is, we're always talking about exercise, right? A lot of people, either they're not motivated, they don't like it, there's a lot of reasons, they don't have the time for it, working hours. But I always tell patients something that it really helps is, and studies have been done and and it's been proven, walking 10 or 15 minutes, just literally walking after a big meal. So I always tell patients, after breakfast, lunch, or dinner. A lot of the times, nowadays after the pandemic, people are working a lot from home, right? It opened that space that people now can work from home. And I tell them, do a chore, right? Put a timer on your phone after you finished eating the salad, the sandwich, right? And then clean up your house a little bit, put 3 songs on, put a timer so that you don't forget, that you have to come back to work. But it does make a difference for when that digestion happens, so that your glucose ideally doesn't get elevated that much. It's something very simple and very small, but it's actionable, and it doesn't necessarily I'm not saying go to the gym an hour, right? It's something that, it's pretty easy to do, walking, or if you're watching TV after dinner, watch the TV show, put a timer for 10 minutes, walk on your living room while you're watching the show, and then you can enjoy the rest of your 50 minutes of the program, sitting down. But it's that small, exercise or movement that helps a lot with, the glucose levels.
Yeah.
Those are great. Thank you. I want to remind everybody in the chat, if you have questions, make sure you put it in there. I want to kind of go back to, I know we mentioned some common misconceptions earlier. Gregory mentioned some. So I want to double back on that, about if there are any more misconceptions about diabetes in the Black community that could impact awareness or management. But I also want to talk about those common myths, because Dr. Woods, you mentioned amputations earlier. So I wanted to kind of also talk about those common myths and misconceptions about that, amputations and diabetes as well. So it's a double, I'm doubling up on the question here. So I'm going to start with you, Dr. Woods.
Sure, thank you. This is a big one. This is what is near and dear to my heart. My father, who just recently passed in June, he actually lost both of his legs to diabetes. And through that, I have learned so much from the patient perspective. When I was in general surgery residency, I assisted when I was on my vascular surgery rotations, in performing amputations. And it's different when you're on the side of the patient. And I think it's an important one to have representation, right? To have physicians and dietitians and clinicians and surgeons and such who can speak the same language, so that patients can talk about what it is that may frighten them or concern them about a diagnosis like this. And so coming from that perspective in the surgery world, one of the first things I would hear people say is, I don't want them to take my foot, or, I don't want to end up on dialysis. I don't want to go blind. And it is a very scary thing, especially when we're talking about the numbers of Black and brown populations being affected disproportionately. So I do want to say that it's not an immediate thing. It's not you get diagnosed with diabetes on Tuesday and you're talking about taking, someone's limb on Friday. There are a lot of steps in between. And I'd like to talk about what that can look like to raise awareness, identify those risk factors, and intervene early if someone is at risk for amputation. So really, we have to remember also that diabetes affects people's ability to feel their feet. So a problem with your foot may not be obvious to you, but it can be something that your family can get involved with. So I implore people who have diabetes, whether or not they think they have problems with their feet, is have somebody look at your feet every day if you can. And at minimum, every time you interact with any healthcare professional, have them look at your feet. When you go to the doctor's office, take off your shoes and socks, and say, hey, can you look at my feet? Can you perform the exam so I can know if I'm getting worsening nerve pain or worsening inability to feel light touch, which is associated with polyneuropathy? It's really important that people have that connection with their feet, because you don't think about what it's like to lose mobility until it's not there. So really getting people in the habit of understanding their risks and knowing what to do. So it can be as simple as looking at your feet, keeping your feet dry. So after a bath, or if you go to the beach or what have you, avoid things that could irritate your feet, because the likelihood of you not being able to feel your feet is higher when you have diabetes. So not walking on hot asphalt, not walking in the beach if there's potential for you to get a wound. And if you do see a wound when someone is looking at your feet, get help right away. Don't say, oh, I can sit on it and I'll deal with it next week, or I can't be off my feet, I've got to work. Have somebody, your regular doctor, look at it right away, and then they can determine if you should see a podiatrist or if you should see a vascular surgeon, what exactly is going on with your feet. But don't be afraid to look at your feet, because unfortunately the statistic we have right now all across the world is every 20 seconds someone is losing a limb to diabetes. So this is really serious, and think about our populations that are even harder hit. So this is something that we definitely should be talking about, that it's not something to be afraid of if you know what to do. And developing a toolkit to help people is something that I'm really passionate about. I'm a member of the American Limb Preservation Society, and that particular organization empowered my dad. He became a motivational speaker for that organization to talk to other Black men who were afraid to go to the doctor, afraid to talk about their feet, afraid to talk about taking insulin, all of that. And so we can help each other by empowering each other. And I'm happy to talk about that more later.
Okay, thank you. And first of all, condolences to you, the loss of your father. And thank you for sharing that. A question popped up in my head when you were talking about the neuropathy, just because I had a show was it last week, a couple weeks ago, and an acupuncturist was saying that they work with a lot of people that have diabetes and have the neuropathy. So my question for you, Dr. Woods, was, can neuropathy be reversed if it's causing a lot of pain? What can a patient do in that case?
I don't know if it can be reversed. I don't treat diabetes myself in the clinic. So if there's somebody that can better answer that question, I'll turn it over to them. But there certainly are medications that you can take that help with nerve pain. One that people know more commonly is gabapentin or Neurontin. And you can go up in the dosage if it's not responding. So that's something I know commonly that people take. And there are other agents that people can take that help, like Cymbalta has been shown to help with nerve pain. So your family physician can help you with answering that question of what's the best drug for you to take that helps. But in terms of reversing it, I'm just not aware of that data. So can you guys weigh in? Have you guys had experience with this?
Not necessarily on the reversing neuropathy,
Yeah.
which kind of leads
Okay.
into one of the myths that I hear about diabetes, or just kind of misinformations, that diabetes is reversible. And this is not to discourage people from taking action and really trying to lower the A1C, but inherently, like, diabetes, once a diagnosis is made, is not necessarily reversible. Because if you think about something that's reversible, you don't have it anymore, and it's almost as if you've never had it before. Your body goes back to normal function. But the truth is, even if you get your A1C down after a diagnosis of diabetes into the normal A1C range, which, as Dr. Wood said, is below 5.7, if you stop doing those things that got you there, your A1C is going to go back up, right? So it's not necessarily reversible. However, it can be what we call put in remission, right? That's more of the term that we utilize to explain what a diabetes, going backwards is. Just more so being in remission than anything. And another myth that I hear, again, I work with a lot of men who don't really understand how diabetes impacts sexual function and erectile dysfunction. This is really big. And actually, I'm doing a seminar next week with the urologist talking about the correlation between diabetes and erectile dysfunction. But this is really big because men with diabetes, uncontrolled diabetes, are 3 to 5 times more likely to develop erectile dysfunction later on in life. And a lot of men that I speak to are then confronted with the erectile dysfunction and just saying, Greg, what should I do? And I'm just like, well, let's work on your blood sugars, and that will in turn kind of like help restore some of that function. So that's another thing that I see all the time. And the last one I want to talk about is this whole concept of diabetes medication being something that will impair someone's life, or being something that will negatively impact their life, which in a lot of cases, the opposite is true. I think that once a diagnosis is made, of course, working with your endocrinologist, whoever made that diagnosis, whatever medication is prescribed, I never advise people to just not take diabetes medication. As a dietitian, we talk about lifestyle factors, nutrition, but we never exclude the role that medication plays, right? Because the nutrition can help, but a lot of times that medication is also needed because some people's condition is really that grave. Now,
Mhm.
as the blood sugars start to improve, your doctor may say, hey, you need to take less of this, take less of this, take less of this, until hopefully, at one point they'll say you don't need to really take this anymore, right? But this whole concept that diabetes medication is bad for you, is going to cause all these types of problems, is a lot of times far from the truth.
Thank you for sharing that. Carolina, how about you?
Um, yes, unfortunately, I don't have, like Dr. Wood said, the data on reversal. I don't know. But I like the fact that, Gregory said, it's in remission, right? And even, for example, I work at the bariatric clinic, specifically at Cedars, and we do see that patients, for example, that had diabetes before, they have the surgery, and then sometimes they either decrease the medication or sometimes they completely are taken off of the medication. But I do guide them and tell them it doesn't mean that there's no diabetes. It's just mean it's in control. Your blood sugars are working a little bit better, your insulin is working a little bit better, but know that you know like Gregory said, if you go back to those old habits and that old way of eating, it might come back. So again, we do discuss that, yes, it's not a reverse diabetes. It didn't reverse it. It just put it into remission for the time being. And let's try and, both work together to keep it that way.
Thank you. Dr. Woods, what is diabetic distress and how does it impact access to diabetes care?
Great question. So to piggyback on what Carolina and Gregory had discussed about reversal, we have to remember again that by the time someone was diagnosed with frank diabetes, they would have lost at least half of their insulin function. So whether it be production or the responsiveness of the receptors to insulin. So it's really important to remember that this is something that, again, is in remission. It's not something where there's a cure, because we haven't quite figured out how to get there. And there's some exciting stem cell research that people are doing with restoring islet cell insulin production, but we're just not there yet. So you really have to work with what you have, right? And so you're working with a lower supply of what you started with. And that is a tough thing for people to accept, because now you kind of feel this like, I've messed up, I made a mistake, there's nothing I can do. And that leads to what we call diabetic distress. And so diabetic distress is the feelings that arise from the daily demands of having to treat and manage diabetes. So those feelings of maybe loss of control, of being able to enjoy what you like to do, or feeling like that number that's on your glucose machine, if it's high, it's going to make you feel like, man, I did bad. I'm bad. I'm having a bad day. Recognizing that diabetes is difficult to control. I like the idea of saying it's in remission. That's something that in the diabetic foot world, we use that term of when someone has a diabetic foot ulcer and we treat it with all the various modalities we have to treat wounds, it can come back, right? And so it's kind of like this race against the clock, and we have to treat it like cancer, understanding that absolutely this is something that can come back, but you don't want people to feel like they're hopeless and there's nothing that they can do. And so talking to diabetes educators, dietitians, people that can recognize those feelings and say, someone is shutting down because they feel that stigma that's attached to treating their diabetes, or they feel overwhelmed, or they can't manage the stress that has to deal with it. We have to educate our providers and family members and caregivers that this is real and that there are interventions to reduce this distress. And it's not quite depression, but it can lead to depression, because as someone has diabetes for a longer time, they may start developing more complications, problems with their eyesight, their kidney numbers are going down, problems with their feet, stroke and heart attack are risks. So dealing with declining health can make people feel like there's no hope for them, and they become worried and have guilt. And so it's really important as clinicians that we're aware when our patients are getting into that cycle of distress, and that we intervene to get them the help that they need.
Thank you. Did either of you want to add anything? Carolina?
Yes, I just wanted, it's great what you just said, Dr. Woods, because I do see it a lot. And I really try to incorporate, the people or the patients that, are diabetic, to tell them you don't have to change your entire diet today, tomorrow, in a week, in a month. I try to kind of, meet them. What is it that you can do, right? So it's really important, I think, for the provider to kind of say, these are your goals, your end goals, and this is what the changes we're going to have to make, and you can make one each week. So it doesn't feel like a burden that I can't have, oh, I want ice cream, I can have it. Or I want candy, I can't have it, right? Since it was just Halloween. So, but learning, and as a provider, meeting with the patient where they're at and what is it enough and what they can actually change, right? Out of the 20 things that you have to change, let's start with 2, and we can work on those 2 this month. And then the next month we'll work and add another 2 goals. But I do think it's really, important from our perspective to kind of meet where the patient is and what they're actually able and can manage for change.
Yeah, and I agree. And I think to continue along the conversation of that diabetes distress, this is where referrals really become important, right? Because a primary care provider or an endocrinologist making that referral to a dietitian, but then if that dietitian is starting to see like, hey, there might be some mental health concerns here that need to be addressed, having a referral to a therapist, because again, we can see eating disorders and disordered eating pop up due to a diagnosis of diabetes, due to that distress and stress that people are experiencing. So having a good referral network, calling in that multidisciplinary team can become very important as well.
Well, how important, we briefly touched on it a few minutes ago, but how important is medication in diabetes management, and what should people know about their options like insulins and medicines like metformin? Yeah, I was like, it's something met.
I can talk about that one a little bit. So you have a lot of different medication options when it comes down to diabetes. It's really not up to the patient to decide what they're going to take. People with type 1 diabetes most likely will be prescribed insulin therapy. That's like the go-to, right? There's another type of medication called a sulfonylurea, which acts like an insulin, but typically insulin is that gold standard for type 1 diabetes. Now, type 2 diabetes, it can be a combination depending on the level of, like how poorly your A1C is. I'm sorry, how poorly your pancreas has been affected by diabetes. Because Dr. Woods talked about how at least 50% of your pancreas production of insulin is impaired. It can go even as low as 20%, and even lower than that as well in diabetes. So there are certain medications that can help the pancreas to secrete more insulin. There are medications that can help the uptake of that insulin into those cells. There are medications that can help you diurese, aka urinate pee, so that your insulin sensitivity is improved. There's medications like metformin that works on the liver to help regulate the glucagon production, which that's a whole nother conversation. But then there's also medications like the GLP-1s, like the Wegovy's and the Ozempics. Those are working in another capacity in the body to help with your overall insulin production and blood sugar metabolism. So there are multiple different options, but then working with your primary care or endocrinologist to figure out which one is best. There are standard criterias that these doctors use to determine what type of medication they are prescribing and giving, that really makes your diabetes care a lot more healthy for you and more personalized to you.
Thank you. Do either of you want to add anything to that?
I'd just like to add a little bit. I agree with everything that Gregory said. And sometimes I also find that people kind of see it as either I have to take this medication for the rest of my life and I'm stuck with it, or I don't want to take it. And just to kind of ease in a little bit, I always explain to patients, you can try the medication. It's your body at the end of the day. We are, as providers, or a doctor basically, is recommending you this medication, but try it out, see how you feel, see what it does to your body, and if you like it and the response as well as with the Ozempic, all these medications, then you have the option of continuing the medication because it's up to you, or not. Obviously, we do want you to take the medication and we advocate for that, but I think that if you give the power to the patient, they're a little bit more open to take the medication, and because it puts the power on them and not on us, right?
Mm-hmm.
Yeah, and I also think too, I want to add one more thing to this, because it's also important to understand what's happening with your body, right? You're dealing with someone with type 1 diabetes. This is somebody who has diminished insulin production. Your body is not producing insulin when you have type 1 diabetes. How your body responds to insulin can work very well, but your body's not producing any insulin. So people with type 1 diabetes who might take a stance and say, I don't want to take this insulin that they're prescribing me, my comment to them is, your body needs insulin. Everyone's body needs insulin. The issue here is that your body's just not producing it. So you have to manually inject it in order for your body to do what it needs to do. So you're not injecting some foreign substance that has no place in your body. You're injecting something that your body requires for you to live and to sustain and to have a thriving life. And that's really important for me when I'm talking to people about diabetes and their options. This is not something that's just coming out of thin air that's going to cause like some huge issues and risks to you. This is something naturally your body is supposed to produce, but unfortunately yours doesn't. And I think that's really important to help people understand a lot of times.
Thank you for that. Dr. Woods, did you want to add anything?
Yes, I want to talk about taking insulin. I remember when my dad had been out of care for a while, and I was taking him to all these doctor's appointments to get him reestablished in care, and his diabetes had gotten out of control and they were discussing taking insulin. And I remember my dad, this 6'4", 220-pound man, was terrified of injecting himself with insulin. And it was something where I said, Dad, you can do it. Let's go. So I went with him to the appointment with the PharmD, who is a pharmacist that's specialized in educating people about their drugs, and in this case, taking insulin. And we practiced, we modeled what it would look like to inject yourself with insulin. And the look of relief that my dad had when he said, Dom, I did it. I was so afraid of taking it. He's like, this little needle, like he had built it up in his head that it was so much more invasive than it really was. And I remember the look in his face, just laughing at himself, saying, wow, I'm so big and I was afraid of this little tiny needle. And he was able to do it. So I want to encourage people not to be afraid of insulin. As Gregory was saying, it's something your body needs. It's to help you, to help prevent further complications down the line. If a doctor determines that you need insulin, it's, I know, a scary conversation, because in the diabetic foot world, people think as soon as they need insulin, oh, that means they're going to take my feet, and again, there are many steps in between that. But it's important to have that conversation and share with your healthcare provider, your family, what your fears are, because it's possible that what you think something is, when you get to that actual point, it's not as bad as you think it is. And so it's definitely worth having those conversations and not closing yourself off and saying, I can't face my fears, but talk to people. Because maybe you can meet somebody who said, yeah, I thought that too. And then I went to the doctor, they showed me how to do it, and it wasn't that bad, and you can do it too. So it's really important that we, again, take out that stigma and those fears and those misconceptions and myths about what it means to treat your diabetes, because they're so many preventable complications that we can eliminate if we have those conversations and open up about the barriers to treating this disease.
Yeah, well, that kind of leads into my next question, which is how can people in the Black community advocate for better access to diabetes care, support, and education within healthcare systems? That I'm just going to throw that question out. Anybody can answer it.
I think a lot of people don't take advantage of their healthcare benefits. And I work as a dietitian. I have a private practice in which most of these insurance companies are covering visits with the dietitian 100%, sometimes 80%, 75%, and you have a copay or deductible. But many times your preventative services can be covered. So taking advantage of your insurance benefits if you are awarded that opportunity to do so. Now, I know a lot of people don't have insurance, so that brings up another conversation, but that's just one thing to look at. I think also too, finding providers that you would feel comfortable seeing is another important thing too. You know, it's perfectly fine for you to do an in-depth research to providers in your area or providers that you would more likely align yourself with. Or if you're trying to advocate for somebody else, sitting down with them and doing doing a Google search and looking for providers in that area and looking at their bios, looking what they do, what they stand for, and what kind of work they've done over their time can kind of ease that apprehension and foster that desire to see that provider. I think these are just a couple of things that we can do as a Black community to really get ourselves through the door of that healthcare provider's office.
Thank you. Carolina, Dr. Woods?
Yeah, I mean, I also think, you usually, when you work in the medical field, right, you know a lot of people, right, whether it's doctors or nurses, right, and I always tell my patients, you can always ask either your doctor or the nurse who helped you if they know somebody that can help you, whatever area it is, whether it's you need diabetes help or a dietitian or, a psychiatrist or a therapist, right? But also just, the internet is great, yes, and of course you can call your insurance, like Gregory said, of course. But I also think that once you're already in there, when you're, with your PCP, right, you can always ask for referrals, or who do they know, or who do they have on their, because we also like to have our list for referrals, right, that we like to send to, right, because it's things that usually people need. So just also, asking your, the doctor that you're meeting with, if they have any referrals or any, somebody that they know that they trust usually, and that they can help you, send them their way.
Thank you.
Yeah.
Dr. Woods? Oh, I'm sorry. Go ahead, Gregory.
I was just going to say one more thing. And we need to not wait till it's too late. If you know that the risk factors are there, if you know you're not feeling well, just take the step, right? And this is something that I tell men all the time. If something doesn't feel right, it's okay to admit it, right? Because one thing we don't want to happen is later on you're dealing with problems that could have, quite frankly, been avoided had you just said something a little earlier, right? So I think that's really something. Let's focus on more preventative care rather than waiting until a diagnosis is made for us to start caring for ourselves.
That's good.
Yeah.
Absolutely, Gregory. You hit it right on the head. And one thing that is speaking specifically to Black men, in hearing my dad get on stage and talk to other Black men and say, brothers are afraid to go to the doctor, and it really hit me because I said, wait a minute, I became a doctor. Like, what do you mean? Like, I'm not scary, and even though we know what to do, how to pick up the phone, make that appointment, it's scary for some folks. And we have to open up conversations where we talk to our men, we talk to people and say, how's your health doing? Is there anything I can help you with? Do you need help going to the doctor. I can drive you, I can take you, or, you can FaceTime me if you need someone to go to the doctor. Diabetes is a community health problem. And we have to understand that isolating ourselves and feeling like it's all on us is how people get lost to care, because they feel like it's all my burden, it's all my fault. And that's not the case. There are people who can help you, but if they don't know what's going on with you, they may not be aware of you. And so it's really important, if you see something, you do something about it right away. And I know it can be scary, but take a friend with you, take your child with you, or a close partner. A lot of people go to the doctor with their spouses. Have an advocate there for you who can help make sense sometimes when it's hard to process everything someone's telling you, like, wow, I have diabetes. Oh, okay, I'm a failure. It doesn't have to be that way. This can be something that we can do as a community, as a family, and come together and help each other, because it's, as you can see, this is now a lifelong disease that people have to face, and it can get daunting for somebody to do this alone.
Yeah, this conversation has been so good. For my last question, and I'm just gonna, what a lot of the things you guys have said have just been empowering, and educational and inspiring. What's one thing that you want people to take away from this conversation? I mean, I know I'm taking away a lot, but if you think back on everything we talked about, maybe something we didn't get to, is there anything that you want to leave with those that are watching right now about diabetes? And we'll start with you, Dr. Woods. I'm always putting you on the spot.
No, that's fine. So being a health equity advocate for diabetic foot disease and amputation prevention, I want to leave people with the sentiment that having diabetes doesn't mean that you're going to lose your feet. And even if that does happen, there are people in your community who can help you get around if you require amputation or even need a prosthesis. It's something where what I want people to remember is to have hope, to talk to people, take your negatives and turn them into a positive. It's not the end of the world. And if anybody has any questions about diabetic foot disease and care amputation prevention, again, I'm a member of the American Limb Preservation Society, and we're having our annual diabetic foot conference known as DEFCON. It's in Anaheim. This organization was founded in part with Mr. Edward James Olmos, who wanted to do something about people in his family who had diabetes and were undergoing amputations. And this is our 24th year, where he'll be presenting the Edward James Olmos Award to some really impactful physicians and other healthcare providers who are doing work in this community. So there's a link there if you'd like to join the conversation and register virtually, or if you'd like to attend the event in Anaheim. It's a 3-day event, and lots of people coming together to talk about the industry and what we're doing to help fight diabetic foot disease. So thank you.
Thank you for sharing that.
Mm-hmm.
And the link is right there, everyone, in case you didn't catch it. Thank you, Dr. Woods, for that. Carolina, do you have anything that you want to leave everyone with, that you want them to really remember from this conversation?
Yes, something that, it's kind of, and it goes along with what Dr. Woods said. So, being diagnosed with prediabetes, or if you're already diabetic, it is not a death sentence, and it doesn't mean that you're bound to have, a limb removed, right? Mm-hmm. Simple, small changes every day can make a big difference. And I always, tell my patients the whole point of investing in your life and your health today, it's not that you can live to be 150 years old, right? But that you have quality of life. And at the end, I think that's what everybody, is looking for, right? It doesn't mean that you have to give everything up. but small changes do make a big difference. So I just I think that, yeah, that's my takeaway, to make sure that you invest in your health today so that you can have a better tomorrow.
Thank you. Gregory,
I
how about
love
you?
that. Very insightful, ladies. That's very insightful. For me, I would say that oftentimes people are looking to make the whole journey in one day. Just kind of piggybacking off what Carolina said, like, oftentimes, like, we're trying to get from A to Z, like, in one instant. But honestly, that A to B can be a huge step in the right direction. And I always find more value when someone says, "Hey, I was able to try this food or incorporate this into my diet, or really, cut down on my alcohol, quit smoking." I was able to just take that one step. Greg, I know there are a million other things that I need to work on, but I'm really, really happy that I was able to do this one thing. That's a really great change, because once that momentum starts going and you start feeling how you start knowing how good it feels, your health is starting to improve, your energy levels are starting to improve, naturally it's going to cause you to make another change and see how else you can invest into your health, into your well-being. So instead of always focusing on A to Z, I just challenge you all who's listening today to take that A to B step and really value those small steps along this big journey.
I want to thank each of you for joining us, because this has been, like I said, a great conversation. I know I'm walking away with some gems, especially that walk for 10 minutes, after, or since I work from home, maybe hop on my elliptical for 10 minutes or so while I watch a show real quick, or a couple of videos. So thank you again. And everybody, stay tuned for part 2 of this series on diabetes. The next one will be November 14th. But for more information about diabetes, head over to blackdoctor.org for articles and resources. And again, we'll see you again on the 14th. But make sure you share this, because of course this lives on the Facebook page and on YouTube. So make sure you share this with, family member, your friends, because you never know who may need this information. So thank you. Thank you again for joining me, and everybody, good night.
Thank you, everyone. Y'all have a great night.
Thank you.